This is a research briefing on the phenomenon of gender detransition. I am Dr. Helios Voss. We examine people who began puberty blockers or cross sex hormones and later discontinued them or re identified with their sex recorded at birth. The evidence is incomplete, definitions vary, and experiences differ widely. We will cover reported rates, reasons, the role of ongoing brain development, and what is known about desistance and regret. Joining me are specialists in the relevant data.
First, the numbers. Clinic based studies with relatively short follow up often report low rates of discontinuation or re identification after starting puberty blockers or hormones, commonly in the range of 1 to 9%. A Finnish nationwide register study found 7.9% discontinued hormonal treatment over an average 8.5-year follow up, with higher rates in more recent cohorts. Some analyses of recent samples report discontinuation in the 20 to 30% range within 4 to 5 years. Systematic reviews emphasize that definitions of detransition are inconsistent. Follow up periods are often too short, and long term data remain weak. The CAS review in the United Kingdom highlighted the overall poor quality of the evidence base for youth medical interventions.
Historical data on childhood onset gender dysphoria showed high rates of desistance by adulthood, often 60 to 90% in older studies, when medical intervention was not the default. The current clinical picture is different. Large increases in adolescent onset referrals, especially natal females, and a shift toward earlier medicalization. Whether the same high natural desistance rates apply to the newer rapid onset presentations is an open and contested question. Some young people who begin blockers or hormones later report that their dysphoria lessened with maturity, while others continue. The brain's executive systems, including those supporting long term decision making and impulse control, continue developing through the 20s and into the early 30s. This is relevant when irreversible or partially irreversible interventions are considered before full maturation.
Reasons for detransition are heterogeneous. Studies and surveys of detransitioners list internal factors such as realization that dysphoria was linked to trauma, autism, same sex attraction, or other mental health conditions, change or fluctuation in identity, and dissatisfaction with physical or social outcomes. External factors include family or social pressure, discrimination, and difficulty accessing ongoing care. Some stop hormones after achieving certain physical changes and do not frame it as regret. Others experience significant distress and feel they were not adequately assessed for comorbidities before medicalization. High rates of co occurring psychiatric diagnoses are consistently reported in gender clinic populations.
From a developmental perspective, adolescence and early adulthood involve substantial remodeling of the prefrontal cortex and related networks that support planning, risk evaluation, and identity consolidation. Identity exploration is normal in this window. Some individuals who experienced intense gender dysphoria in mid adolescence later describe it as having resolved or shifted as their sense of self stabilized. This does not mean every case follows that path. Persistent gender dysphoria exists, and some people report lasting benefit from transition. The difficulty is reliable prediction at the individual level, especially when the evidence base for medical pathways in youth is acknowledged to be weak by multiple systematic reviews.
Methodological problems recur. Many studies lose patients to follow up. Clinics that affirm quickly may not track those who later discontinue. Surveys of detransitioners are often convenient samples and cannot yield precise population rates. Conversely, very low regret figures sometimes come from studies with short observation windows or narrow definitions. The honest summary is that we lack high quality, long term, population based data on how many people who start puberty blockers or cross sex hormones in adolescence later detransition, and for what reasons.
For clinical practice, the implications are caution with irreversible steps before maturity, thorough differential diagnosis of co occurring conditions, and support for those who do detransition. Detransitioners report needing medical care for the effects of hormones or surgery, psychological support, and spaces free from both political instrumentalization and social stigma. Research priorities include longer prospective cohorts, clearer definitions, and outcome measures that capture identity change, mental health, and physical health over decades rather than years.
To summarize the current state of knowledge, detransition and discontinuation occur at rates that vary by study design and definition, typically higher than the lowest figures sometimes cited in public debate and lower than the highest activist claims. Brain development continues well into the third decade of life, which is relevant to capacity for decisions with lifelong consequences. Experiences range from relatively straightforward cessation after identity shift to profound regret and medical complication. The evidence base remains limited. Better long-term data and careful individualized assessment are required. This concludes the briefing.